Hello and welcome back to my channel. So I've had some interesting information with regards to a recent test I had, something that I was not expecting, to be perfectly honest with you, and trying to get my head around the prospect of what may be in store for me is challenging, to say the least. This is not something that I'd ever expect my life to need or warrant. At the minute, it's on the basis from my transanal irrigation rectal nurse. But ultimately it will be the surgical consult's decision. But basically, I have, if you don't follow me already, and you're new to my channel, I have Ehlers-Danlos syndrome. As a result of ADS, I have a lot of gastrointestinal issues. One of those issues is I have many prolapses. So I have a cystocele, which is mild, which is basically a mild bladder prolapse, which is becoming worse. I also have bladder retention, so I basically get urinary retention. I have just found out that my uterus is prolapsing backwards, and my bottom basically has a rectocele at the highest degree angle of 120 degrees, which basically means it's quite a sharp pocket that it's created in my rectum. And as a result of that, I also have what's known as a mucosal prolapse. I have been basically using FME's bar to basically manually evacuate to help me go to the bathroom for many years. And I have a very awkward bowel, so if I take too much laxative, it sets my IBS off. And obviously my bowel works quite slowly as well, so even just taking a small lot of laxative, it kind of doesn't really do a lot straight away, even within 24 hours like it's meant to. Sometimes takes longer than that. So basically my stomach and everything just works too slow, or not at all. So I went for a sigmoidoscopy, basically to check how my prolapse was, how advanced it was. Obviously took some biopsies. It's just normal procedure, I believe. And I'm going to tell you a little bit about a sigmoidoscopy in case people don't know what a sigmoidoscopy is. So a sigmoidoscopy is basically a flexible tube, similar to a gastroscope tube that you'd see in endoscopy. The procedure is done in the exact same department, only the tube, instead of going into your mouth and down your throat into your digestive tract that way, it goes up your bottom instead, and it basically has a look around by pumping some air into your bottom to dilate things, and then obviously they'd be able to have a look around. In order to do this, they need to send you what's known as an enema out in the post, or prior, if you're in hospital, they'll give it you on your ward or whatever, about an hour before your procedure. When you attend the hospital, you will obviously check in, you'll be told where the toilets are in case you still need to use the facilities, and then once you are booked in and called through, you will then go through the procedure with your nurse who calls you through, and you will also be asked a series of questions with regards to your health, and to see whether you have signed your consent form and whether you agree to certain things with regards to the consent form. So in extremely rare, and I mean extremely rare cases, there can be complications which could cause perforations, where you may need a further treatment. You may have some bleeding, which again could become heavy. You may need a blood transfusion for that. But these are extremely rare occasions and they very rarely happen. If you are an extremely anxious person, then they may or may not give you sedation. Usually that's only mild. I've never personally needed a sedation for a sigmoidoscopy, if I'm perfectly honest with you. I've never actually needed a sedation. However, they sometimes have Entonox, also known as gas and air, on standby, because as they are navigating through your large intestine, there is something called the Sigmoid Junction, which is like a sharp bend which they need to get round in order to get to your transverse colon, and this can become a little bit like painful at times, depending on the type of bowel issue that you may be going for. For me personally, because obviously I'm fed into my bowel, and obviously I don't deal very well with dispersing air myself from my own body, having air pumped into my body that is not designed to be there can cause a lot of discomfort. So this time round, I did actually use the Entonox to help. If they feel that you're taking Entonox too quickly, they will ask you a question in order to get you to answer the question rather than you breathing on the Entonox, because too much Entonox can cause dizziness, and then dizziness ultimately will cause you to pass out, because you're not getting enough oxygen to your brain basically. So once you are also once you've gone through your consent form and everything, you will then be taken to a changing room. Typically the changing rooms have a basket in them, which will contain a pair of navy blue, almost like cycling shorts, that has a hole in it, that the hole goes to the back of you, so obviously they can get to your bottom okay. So you'll basically strip everything off from the waist down, and they will obviously ask you to put a gown on as well, especially right now with COVID being quite high. They will recommend that you get changed into a gown. It also keeps your clothes clean and tidy, because obviously things are getting shoved in places that you don't really want secretions on your own clothes for. So basically they will give you the shorts, you strip from the waist down, you put the shorts on, and you have the hole in the shorts at the back. The hole is pretty much similar to what you would find on a man's pair of boxer shorts, where it's obviously open at the front on a man's pair of boxer shorts, but obviously these shorts open at the back. And this basically keeps your dignity and your modesty intact, so therefore it's less embarrassing for you because there's not going to be anything on show. Now, typically once you've got changed, you fold your own clothes up, put them in your basket along with any belongings you may have, like your bag or your phone or anything else, and then that basket will go into the procedure room with you. Once you're in the procedure room, you will see there's a few people around. There's usually probably about 4 people. There's someone to obviously type up the findings on a computer. There's a nurse around in order to relax you and to keep you company and hold your hand if necessary. Also hand you the gas and air if they feel that you may need it, and reassure you. There is a nurse that will be there to basically help the doctor out who is performing the procedure, and obviously the doctor in general. You'll see a few monitors and screens in front of you. If you're not very squeamish or anything, you can watch the screen and you can actually see your colon on the screen while they're navigating it. I find that type of thing pretty cool because obviously I'm into that type of stuff, but you know, I'm into medical stuff, so I'm quite happy to watch. I was the same when I had my cardiac ablation, because let's face it, the sedation didn't work for that one. But yeah, I am interested in watching that, so if you're interested, you could watch it. By that point your colon should be fairly clean because obviously you've had your enema, and usually before they start the procedure they will probably give you a examination, like a manual examination, so that they can check for themselves to see whether they can feel anything abnormal. They may also get you to bear down a little bit just in case there's anything untoward. They want to check your muscles and your sphincter's okay. And depending on what you're there for as well, they might recommend doing this. For me personally, like I said, I went for sigmoidoscopy because I have a prolapse and I have quite a significant rectocele, and this was noted on my examination, and they took a couple of biopsies. Now, I naturally suffer with irritable bowel syndrome, on top of all my other health conditions, and I have been doing transanal irrigation for a good few months now, in order to help me go to the bathroom so that I'm not having to self-evacuate, and taking laxatives around about 2 or 3 times a week, in order to keep my stool soft enough for me to be able to go to the bathroom, but not too soft to the point where I'm struggling to get it out, given the fact that I have a prolapse, which can obstruct things. Now, I went for the sigmoidoscopy because my prolapse seemed to get worse. I didn't know I had a prolapse originally, and obviously this started to develop, and I'd had some rectal bleeding. So I was advised not to do the irrigation until I'd sought help, and my irrigation nurse thought that my prolapse looked a bit dusky, so she was worried that I may have had some strangulation going on. So I went for a sigmoidoscopy to check for all of these things. What they found was that I had a mucosal prolapse, and that mucosal prolapse was bringing out with it some hemorrhoids. Now, I already knew from previous sigmoidoscopy many years ago that I did have internal hemorrhoids. Obviously, over time, these hemorrhoids can actually grow, and given the fact that I actually have an extra pocket in my rectum that should not be there, i.e. the rectocele, then obviously this can make things a little bit worse, and that pocket also creates a pocket basically to make it harder for you to go to the bathroom, because of the fact that that pocket then holds the stool instead of it coming straight out. So the best way I can describe it is, instead of having like a straight colon like this where your poop would be able to come out of it no problem, my colon kind of does this. So it kind of comes down, and then there's a big pocket, and then basically it makes it harder for me to poop. That's probably the best way I could show it. Sorry, I'm using my inhaler as a description. And because of this, it's very hard for me to go to the bathroom without having to do irrigation or to manually evacuate, using a Femi's bar. And yeah, that's pretty much the basis. So the reason why I'd had rectal bleeding is because I had punctured a hemorrhoid, which I did not know about, and that was because I was trying to push the whatever was coming out back in. I was told it was definitely a prolapse, but it was bringing out hemorrhoids as well, and as a result, I was also told that in order to fix the rectocele and the mucosa, they would have to put in a mesh types thing, which I'm not really sure what it's made from, but they would have to put a mesh in. However, because I've got EDS, and because of my irritable bowel syndrome, and because of how pliable my tissues are, they basically told me that I would not be a candidate for the surgery that I need to have in order to fix these issues, because with the tissues in my rectum being so friable, they believe the tissue would not hold the stitches that need to hold the mesh in place. So they basically said that the best thing for me to be able to do, because I'm not a candidate for that type of surgery, would probably be to take regular laxative and to do my irrigation. However, my symptoms will progressively get worse over time, and then they'd have to look into more different things to possibly be able to do in order to try and fix that. Otherwise, I will become incontinent basically. Now, obviously, I'm not even 40 years old yet, and it's looking by the time before I'm even 45, I would probably be incontinent. Now, I went for my sigmoidoscopy on the 7th of October. Sorry, not October. We're on the 7th of October today. I went for my sigmoid in September 7th this year. So about a month ago, I went for my sigmoid. And I am due to see the rectal surgeon, or at least a general surgery consultant, on the 1st of November, which originally was a telephone consult. It's now been changed to a face-to-face. And I have been trying to do what the sigmoidoscopy doctor had told me with regards to the laxative and the irrigation and everything. However, within that month, my prolapse has actually worsened to the point where it's harder now for me to actually put all of it back in using a warm cloth and stuff like that. So I spoke to my rectal nurse yesterday who helped me with the irrigation, and she told me that chances are I will need surgery. I did explain to her what the sigmoidoscopy doctor had said, and where they told me that I'm not a candidate for surgery to fix the rectocele or the prolapse, because they believe 100% because of the fact that my internal tissues are so friable, it would not hold the stitches in order to hold that mesh in place. And she said, no, that's not what I was thinking. I think that you're going to end up going straight for stoma. Now, having a ileostomy or a like a colostomy or anything like that wasn't something that I was anticipating. I was hoping they would be able to fix the rectocele and the prolapse and things would be okay. But because of the fact that obviously your bowel is naturally contracting, mine stretches too much because of my EDS, and because of the fact that the tissues are friable, chances are that if I was to have the procedure that is naturally supposed to be done for this type of thing, the first bowel movement that I would have, I would probably end up tearing the stitches, and I would probably end up not only bleeding because obviously the stitches would have torn, but the mesh and everything that they would have done to put in me would just basically come back out, and I would be no better off basically. So my nurse thinks that the only option for me left now is to go for stoma. I don't know what type of stoma that would be. I don't know whether it would be an ileostomy, a loop ileostomy, or whether it would be a like a colostomy. I honestly do not know. But at the moment this is all up in the air, like I said, because I have to speak to the surgeon first. She may completely agree with the rectal nurse and say, look, this is the only option you've got, otherwise you will become incontinent by the time you are 45, or even before. Or she may disagree with both doctors and that, or both the doctor and my irrigation nurse, and decide to still go with the mesh and the fixing of the mucosal prolapse. It all depends on what she wants to do. Obviously you guys know that I will be getting my NJ tube changed to a PEG J tube, which would obviously mean that I would already have a stoma in my stomach. For those who don't know, a stoma is basically a hole that goes into your abdominal wall, and obviously a tube or your bowel or a tube will come out of it, or your bowel will come out of it, or even like a new pathway for urine will come out of it if you have a cystoscopy, not a cystoscopy, like a urostomy done, but I don't need that. But trying to get your head around the fact that you've got to have a feeding tube and a permanent feeding tube that's going to go into your stomach, to then be told that there's a very high chance that I'm going to end up needing a stoma to basically have bowel movements from now on. So I'll end up like basically pooping in a bag. Is quite a lot for me to get my head around. So I don't know ins and outs yet. Like I said, they did take a few biopsies from me, and I think that's another reason why they know my tissues are quite friable. The last time I had a sigmoidoscopy was a few years back, and I didn't have Entonox for that. I'm talking like probably 8 years ago. I didn't have endoscopy for that. I didn't have no, it was less than 8 years ago. It's about 6 years ago, 5 or 6 years ago. I didn't have endoscopy for that. sorry, not endoscopy. I didn't have Entonox for that. And they did tell me that when they took the biopsies, then it came back to say that I did have irritable bowel syndrome and obviously some internal piles. I'm not expecting these biopsies to come back and tell me anything different. But biopsies can take anything from 2 to 12 weeks to come back, and my procedure was done on the 7th of September, so I will probably get them results back on the 1st of November when I see the colorectal general surgery doctor, and hopefully she will have a better insight. Once I know more, and if a stoma is the way forward, I will come back and update you guys on what that appointment goes and how it goes. But yeah, that's basically what a sigmoidoscopy is, what my findings were, what I'm now possibly looking at in the future, which is something that it's hard enough to get around the fact that you're going to have to be fed through a feeding tube in your stomach for the rest of your life. So to be told that there's a chance that you're going to end up having to have another pathway in your stomach or in your abdomen in order to basically have a bowel movement in is a lot more to get your head around. So yeah, and I mean, I don't even know the indications of regards to having a stoma along with a PEG J tube. I don't even know if both of them are feasible. I'm presuming that they would be, but I'm not 100% sure. And yeah, I will do another video with regards to what my gastric doctor said about my PEG J surgery. But as far as I'm aware, looks like I'm looking at having a bowel stoma fitted at some point. Like I said, whether that's a colostomy or an ileostomy, I wouldn't know which one that would be, because otherwise my prolapses are just going to get worse because of my EDS. So, but thank you very much, EDS, for causing all this havoc in my body. It's what having classical like EDS is, I suppose, or you know, hypermobility EDS with classical crossover, as I like to call it, because I just couldn't afford the test to prove that I had classical like, even though my doctor was like, yep, that's what you have. So yeah, I hope you've enjoyed this video. I hope you understand what a sigmoidoscopy is. If you're due to go for a sigmoidoscopy yourself, and are a little bit nervous about, you know, your modesty or your dignity or anything like that, like I said, you wear these shorts, and the shorts keep your modesty and your dignity intact. And the nurses and doctors have a way of keeping you comfortable. I would probably say the only embarrassing part of having a sigmoid done is the fact that obviously they insert air into your colon so that it can like dilate it slightly so that they can navigate the tube properly, so that they can see what they're doing. And as they're retracting that tube, that air obviously naturally escapes with the tube, and you can let out some flatulating sounds, which I always end up apologising for because I'm polite, but the doctors and nurses are completely used to it. So yeah, don't be embarrassed about letting out the little trumpy noises because they are completely used to it, and it's just your body's way of getting rid of the air that should not be there. It does sound a little bit embarrassing, you feel a little bit mortified, but it's a natural response, and like I said, they are used to that. So it's important that you go for these tests, especially if you've got any type of rectal bleeding that's abnormal. All rectal bleeding is abnormal, by the way, so if you have any bleeding whatsoever from your bottom, you please go and seek help via your GP and get necessary tests done. They may or may not take biopsies depending on what's going on, but if they do, don't be worried about it. You don't feel them, and if you do feel uncomfortable, like I said, you can ask for Entonox, and complications for a sigmoidoscopy are extremely rare. I have friable tissue and they didn't do any damage to me, so like I said, you will be absolutely fine. You're in good hands. There's always somebody there to keep you calm and collective and relaxed, so please don't worry about it, but please go to put your mind at rest if you have any concerns with regarding abnormal bleeding or any abnormal lumps or anything like that that you notice. So yeah, take care, and thank you for watching, and I hope this video has made a lot of sense. For follow-ups and updates, please make sure you press the subscribe button and the bell, and the bell will alert you once you've subscribed to when I'm posting again. But yeah, thank you for watching, and I'm sorry this video was so long. Take care and enjoy your weekend. Bye.